Welcome to the brand new topic on pulmonary medicine. Whenever you think about the pulmonary medicine, the most important things are the foundations in pulmonary medicine, which forms a major role in understanding the future core concepts on pulmonary medicine. So with keeping that in mind, I'm going to discuss a lot of basic and important stuff in this particular section, which will be of mighty usefulness when you go to the future topics, which I'm going to discuss in detail later on. But let us kick it on without wasting much time. So the first thing I'm going to discuss will be on the airway generations. So what I'm going to tell first is going to be on the airway generations. So this concept of airway generations was originally called as something called a Weibull's model. The name is very important. Once again, it's a question. Weibull's model. So what Weibull's model is telling is the fact that you have 23 generations of the airways. You have approximately 23 generations of the airways. Those 23 generations of the airways you can divide into something called a conducting zone and something called a respiratory zone. So I can tell once again, this is called a conducting zone. And second one, you have something called a respiratory zone. So what are the functions of a conducting zone? The conducting zone includes the first 16 generations, starting from the main bronchus up till the terminal bronchioles. Clear? So let us break down the conducting zone once again later on. But anyway, it starts from the bronchus, the primary main stem bronchus, which divides into right and left bronchus. That's the main stem bronchus. From there up to the terminal bronchioles, you're going to have the conducting zone. And typically, conducting zone, the major, function, if you ask me about the conducting zone, it's useful in mucociliary clearance because they have a lot of cilia and they have the escalator function, which means they push the organisms or any dust out of the system, and they're going to humidify the air as well. And one important aspect of the conducting zone is they don't have any gas exchange happening there. There's absolutely no gas exchange whatsoever. There is no gas exchange happening in the conducting zone. You have to be very, very clear about that. Second thing, if there is no gas exchange happening in the conducting zone, which means they are the ones that contribute to the dead space. That is nothing but the anatomical dead space. Clear? Anatomical dead space, later on we will see how it is found out. Anatomical dead space is actually calculated with the help of something called Fowler's method, which is single breath nitrogen washout method, which we'll discuss in detail later on. But right now, it is anatomical dead space that is nothing but 150 ml according to your physiology textbook. But I will tell you it is 1/3 of the tidal volume is the one that is going to contribute to the anatomical dead space. And this anatomical dead space is contributed by the conducting zone only because there is no gas exchange happening over there. Next thing, apart from that, this conducting zone has a very good cartilage support in general. Cartilage support. But overall, the cartilage tends to decrease as you move down the conducting zones. The cartilages tend to decrease, which means the trachea, bronchi are the ones which are going to have major chunk of the cartilages. But as you move down and down and down, the cartilage is going to decrease. Then, these are the zones which are going to provide high level resistance, which means these zones are going to have high resistance. If you ask me where are the highest resistance, you are going to get in the segmental bronchi. More than 80% of the entire airway resistance is actually present on the segmental bronchi. Segmental bronchi means this generation number 3. This is what I'm going to call it as segmental bronchi. Clear? So this is the one that's going to give highest resistance among the entire airway. At the same time, these are, and the why you ask me they are providing such a high resistance is because they are arranged in series. That is the reason. Because they are arranged in series, they are going to have a very, very high level resistance. They are not parallel circuits. You do have studied in elementary physiology, while parallel circuits do not provide resistance, whereas series circuits definitely are going to provide a high level resistance. Clear? At the same time, because they are having high resistance, the airflow tends to be turbulent. Application, they are going to produce high frequency zones because the airflow is turbulent, but these high frequency zones you will not be hearing outside the chest wall through a stethoscope, because there is something called an alveoli after the bronchus that is going to filter these high frequency sounds. You will be getting only low frequency sounds, which means alveoli are going to act as something called a low pass filter, which filters the high frequency sounds coming from the bronchus. Clear? Then, what is the vascular supply? Vascular supply of the conducting zone is predominantly made of your bronchial vasculature. That is a bronchial artery and the bronchial veins. Bronchial veins are going to drain the conducting zone, and bronchial arteries are going to supply the conducting zone. Okay, so what about the respiratory zone? So we have seen all the properties of the conducting zone now. What are going to be the properties of the respiratory zone? It's quite opposite. Respiratory zone is the place where you are going to get the gas exchange. This is the place where you typically are going to get the gas exchange. Point number one. If suppose some alveoli are non-functional, probably you might have something called alveolar dead space, which might add up to the anatomical dead space and contribute to the physiological dead space, which is further calculated by the Bohr's equation. All of those we are going to discuss is later on, not now. So gas exchange, number one. So these are the places. So what are the things that contribute to the respiratory zone? The respiratory bronchioles, which contribute to the 3 generation, that is 17 to 19, and the alveolar ducts, which contribute to another 3 generation, that is 21 to 22, and the final alveolar sacs contribute to the last generation, that is 23rd generation. So these are the areas of gas exchange. Next, they have a very, very little cartilage support, or in fact they do not have a cartilage support in the first place, but they have very good smooth muscles. As you move distally, the cartilage may decrease, but the smooth muscles will keep on increasing. They are very rich in smooth muscles because they are the ones that produce this changes in the airway size and radius, diameter and resistance sites and all. They are the ones that are going to adjust as well. Anyway, the cartilage support is very, very less in case of a respiratory zone. At the same time, if you ask what are the vessels that are supplying the respiratory zone, it is the pulmonary vasculature. The pulmonary arteries are the ones that supply the respiratory zone, and the pulmonary veins are the ones that drain the respiratory zone. Clear? And it has to, because the pulmonary arteries carry deoxygenated blood, and this does the gas exchange, so they get oxygenated there and they carried back by the pulmonary vein. So this has to naturally be supplied by the pulmonary vasculature only. And since they are arranged in parallel circuits, their resistance levels are extremely less. At the same time, you can see the flow will be streamlined, not turbulent here. The flow is going to be absolutely streamlined and it's not going to be turbulent. So these are some of the differences between the conducting zone and the respiratory zone. So now let us go for certain aspects of the conducting zone. You can see this is the trachea, and the trachea contributes to something called generation number 0, and that is very, very important. No, it's the main bronchus that is going to start with the generation number 1. So let us put a trachea, otherwise called as windpipe in layman's term. This trachea is going to contribute to generation number 0, and it's going to have cartilaginous rings, you know that, and which is further divided into 2 bronchus, that is a right mainstem bronchus and a left mainstem bronchus. Right mainstem bronchus and a left mainstem bronchus. So what I have drawn here, you can see this right mainstem bronchus is straight. Clear? Right mainstem bronchus is more straighter, and you can see it's more shorter, and if you see it will be more wider also. If you can see, it will be more wider also, which will prove in some time. And similarly, the left mainstem bronchus will be more horizontal, which means it's not straight, it's more horizontal than vertical. It's like this. At the same time, it is more lengthier. At the same time, it is going to be little bit more narrower compared to the others. Narrower. So these 2 things make the fact that the right side is the one which is more prone for aspirating any content. So for any aspiration, the easiest way for that aspirated material is to move into the right bronchus because of its straighter, shorter and wider. That's the reason. But at the same time, the left bronchus or the left lung is less prone for aspiration because of the characteristic of the left main bronchus. Let us see the characteristic of these three major like airways. First the trachea, then you have the left main bronchus, or right, first we'll write the right main bronchus and then we'll write the left main bronchus. So what is going to be the length of these tubes? The length here is going to be 11 to 13 centimeter and the length of the bronchus is going to be 1.5 to 3 centimeter, the right one. The left one is going to be 4.5 to 5 centimeter. I already told you the left is going to be of more length and you can see it. It's going to be of more length. Similarly, what is the diameter? The tracheal diameter a little bit varies. For example, in females, it's supposed to be somewhere around 10 to 21 millimeter or 1.1 to 2.1 centimeter, and in males, it's supposed to be 13 to 25 millimeter or 1.3 to 2.5 centimeter. What are the diameter of the bronchus? Right bronchus approximately 15 millimeter and left bronchus approximately 13 millimeter. You can see the right is the wider one, which I told you already. Clear? Now, what is the cross-sectional area? Again, the area is more for right bronchus only compared to the left bronchus because of the more width it has. The cross-sectional area of trachea 3.2 to 3.5 centimeters square because it's sheerly of big length compared to the bronchus. That's why here it is 2.2 centimeters square and the left main bronchus is 2.1 centimeters square. And again, the area is going to be more for the right mainstem bronchus only. So these are some of the numbers that you might be needing to know. Apart from that, nothing is much important here. After this, you also have to know this trachea has some important anatomical relationships. The most important anatomical relationship is at its bifurcation, which typically happens at the T4 level, vertebral level T4. So this bifurcation called the carena is going to happen at the T4 vertebral level. And you have something called a carinal angle, which is typically somewhere around a wide range, that is 35 to 90 degree, average being 75 degree. And it's approximately around 35 to 90 degree in usual circumstances. So this widening of the carinal angle may happen in patients who are having left atrial enlargement because left atrium is going to compress on the left mainstem bronchus and it's going to push more and more so that the carinal angle will become more and more wider. That is what we refer to as something called as splaying of carina or widening of the carinal angle that typically happens in a patient with mitral stenosis or any patient who is having left atrial enlargement. Clear? And some important anatomical relationships of trachea, that's what we have been discussing. So first, let us see, when you take a trachea, when you take a cross section, let me put a cross section and we take a trachea here. We take a trachea here, what are the things that are present anteriorly and what are the things that are present posteriorly? So posteriorly, the two most important structures that you are going to encounter is the esophagus and the descending aorta. So this is the aorta and this is the descending aorta. And anteriorly, you are going to encounter certain important structures like thyroid, which is a very important thing that is present anterior to the trachea. At the same time, you are going to encounter aorta again, but here in the form of ascending aorta. And you also have the brachiocephalic trunk and the SVC. So superior vena cava and the brachiocephalic trunk, all these things have anterior relationship to the trachea. So actually this relationship with the trachea is really important, especially the esophagus and the ascending aorta and descending aorta relationship, along with the thyroid also is important for various anatomical reasons. Anyway, see, these are some of the important relationships that you need to know. So we finished the first level. First level, I told you it will be let us put one here, let us put one here. These are the first level of airway generation, that is the mainstem bronchus. First division, that is where it starts. Trachea doesn't divide. The first division where you start is the bronchus, that's why you call it as a first generation. And the second generation, let me put a little bit different, and it's going to become lobar bronchus. Let us assume this is the bronchus for the upper lobe, and this is the bronchus for the middle lobe, and let us assume this is the bronchus for the lower lobe. So these are the lobar bronchus. So you can call these as generation number 2. So you have an upper lobe bronchus on the right side, middle lobe bronchus on the right side, and lower lobe bronchus on the right side. Similarly, you have upper lobe bronchus and a lower lobe bronchus. So you can tell this is a lower lobe bronchus and this is an upper lobe bronchus. This is again generation number 2 for the left lung. So it gave a bird's eye view. You can see this. What you are seeing is these are the lobar bronchus. Lobar bronchus. That is what we called as generation number 2. So remember, the right lung has 3 lobes: upper lobe, middle lobe, and the lower lobe. And be very, very sure the left lung has only 2 lobes, upper lobe and the lower lobe. The left lung has no middle lobe. Probably the lingula or the lingular lobe is supposed to be called as modified middle lobe, but we don't call that. But anyway, it's a lingula is a part of the upper lobe according to many anatomical textbooks. You don't have a middle lobe in left lung. Very important point. Clear? If you take the upper lobe and the third generation you need, the third generation is what we refer to as something called bronchopulmonary segments. So we are entering into the third zone. This third division of the bronchus will enter the bronchopulmonary segments, which is again a very, very important point to know. So what are the bronchopulmonary segments and what are the importance of these bronchopulmonary segments? Let us see to it. So each and everything which I have drawn are the third order bronchus. Let me put 3 here. These are what we refer to as segmental bronchus, and these are the ones which are going to produce maximum resistance among the entire conducting airway system. Clear? So what are these? These are nothing but the third level. Let me put in a different color, maybe in blue probably. These are the third generation of airways. These are the bronchopulmonary segments. These are the segmental bronchus that are supplying the bronchopulmonary segments. What are the bronchopulmonary segments for the upper lobe, right upper lobe? You have something called apical segment, anterior segment, and a posterior segment in the right upper lobe. Similarly, in the middle lobe, you have a lateral and a medial, right middle lobe, 2 segments. And similarly, in the lower lobe, right lower lobe, you have 5 segments. One is you have superior segment, then you have medial basal segment, then you have a anterior basal segment, then you have a lateral basal segment, and then finally you have a posterior basal segment. So you have 5 bronchopulmonary segments. So totally, if you say how many bronchopulmonary segments are there in the right side, 3, 2, 5. So which means totally I can tell there are 10 bronchopulmonary segments are there on the right side. Similarly, you have a lot of bronchopulmonary segments on the left side. So like, let me put like this: 1, 2, 3, and 4. And you have 1, 2, 3, and 4. So how many bronchopulmonary segments are going to get on the left side? So let us put this is generation number 3. This is the third generation of bronchus, airway division. So you can see what are the bronchopulmonary segments of the left lung, so left upper lobe. You have number 1, something called apico-posterior. They have mixed the apical and posterior together. Then you have anterior. Instead of medial and lateral of the middle lobe, here you have superior lingula and an inferior lingula. So 4 segments on the left upper lobe. Then you have 4 segments on the left lower lobe. Number 1, you have superior and anteromedial basal, which means anterior basal and medial basal, they are mixed here, they are combined here, and they made it anteromedial basal and posteromedial basal or posterior basal, and finally you have a lateral basal as well. So if you see here, you have 4 here and 4 here. So totally you are going to have 8 bronchopulmonary segments on the left side, which means this is the standard given by many textbooks. You have 10 on the right side and 8 on the left side. So these are the bronchopulmonary segments that you have to know. And what is the idea of this bronchopulmonary segment? So why these bronchopulmonary segments are considered as special here? Because point number one, these bronchopulmonary segments are supplied by a separate segmental bronchus, which we saw already. This is generation number 3. We know that. And similarly, they have a separate segmental branch of pulmonary artery. And they are drained by a separate intersegmental part of pulmonary vein. Intersegmental branch or intersegmental part of a pulmonary vein, and typically they are surrounded by a connective tissue septum called intersegmental septum. They are separately done by a segment called intersegmental septum. So which means if I draw two bronchopulmonary segments here, for that matters, if I draw two bronchopulmonary segments, they will have a separate pulmonary artery. Already they have a separate segmental bronchus, and they will be drained by a separate intersegmental pulmonary vein, intersegmental part of the pulmonary vein, and they are going to be surrounded by a intersegmental septum as a whole. Which means what I am trying to tell is these are independent units. So if you surgically remove one bronchopulmonary segment, it will not interfere with the function of the other bronchopulmonary segment. They are functionally independent units. They are not dependent on the other bronchopulmonary segment to each other. Clear? So this is the idea of a bronchopulmonary segment, and this is why these bronchopulmonary segments are important in understanding. So we discussed till about segment number 3. Now from segment number 4 till segment number 16, or from airway generation 4 to airway generation 16, these are typically called as bronchioles. But some textbooks tell generation number 4 to 10 as proximal bronchioles or proximal bronchioles, or they also tend to call it as something called subsegmental bronchi also. Subsegmental bronchi also. These are terminologies given to these bronchioles, but I believe that if we stick on to the term bronchioles from generation number 4, so till generation number 16, that is terminal bronchiole. So no need to confuse the term, just remember the term, it's a bronchiole, that's all. So this is what is going to happen. Clear? So all these things I have discussed in detail. What are the generations? With this basic understanding, let us move on to the vasculature. Anatomy of the hilum of the lung, again, it's very important for an anatomical aspect, which we are not going to discuss because it doesn't have any much functional relevance to what we are going to discuss in this current section. But anyways, let us see some of the vasculatures. I told you, your conducting zone is going to be supplied by bronchial artery, and it will be drained by bronchial vein. So let us put the bronchial artery here, and we put a bronchial vein here. So where does the bronchial arteries originate from? The left bronchial artery is going to originate from the thoracic aorta, which means from the aorta. The right bronchial artery can originate either from the thoracic aorta, or they can also originate from the third intercostal artery, which is in turn, third intercostal artery in turn is a branch of aorta only. So third intercostal artery. So possible. So very commonly in exam, they will expect this answer only. Third intercostal artery, that's where your bronchial artery originates from, very commonly. Bronchial vein. So what is the drainage of the bronchial vein? On the right side, obviously they are going to drain into the azygos. There is no doubt about that. They are drained into the azygos on the right side. On the left side, they are going to drain into another system called accessory hemiazygos. Or it can drain into the superior intercostal vein. So these are some of the important vascular supply. And at the same time, these bronchial veins and pulmonary veins may have some significant shunting they may have some significant shunting process, which means they might cause a physiological shunt. I mean, because the conductive zone and respiratory zone are overlapping. So since the respiratory zone is supplied by pulmonary veins and drained by pulmonary veins, and the conductive zone is drained by bronchial veins, there might be overlap where your bronchial venous blood may be directly put into the pulmonary veins, which means there will be shunting of deoxygenated blood to the oxygenated blood, which might cause some mixing. I mean, this one area, this bronchial vein, pulmonary vein, anastomosis, is one area where you get a physiological shunting of blood rather than anatomical shunting, but that is of nil significance in routine practice. So you have to note about that. But you still, that's one important site of physiological shunting of blood that is happening. That's what you have to know. Apart from that, if you ask about the respiratory zone is actually supplied by the pulmonary artery and drained by the pulmonary vein. You know, there are 2 pulmonary arteries and there are 4 pulmonary veins. Pulmonary arteries are originating from the right ventricle, and through the, like your respiratory zone, they travel and they form pulmonary veins, which are going to enter the left atrium and further into the left ventricle. So this is the normal basic anatomy which everyone knows. So two pulmonary arteries you have, that is the right pulmonary artery and left pulmonary artery, which starts from the main pulmonary artery. Initially you have main pulmonary artery which gives rise to right and left pulmonary artery, and finally, like pulmonary veins, if they ask you, there are 4 pulmonary veins which are going to enter the left atrium. Clear? So 4 in total. So these are some of the important things about the vasculature. And one important thing that you might be needing to know about this pulmonary artery related thing is, you know that you have a right ventricle. From the right ventricle, you have a pulmonary artery. I can draw separately because there is no space. Right ventricle. So, and you have a pulmonary artery that is coming out of the right ventricle. This is something called the main pulmonary artery, and which is going to divide into your right and left pulmonary artery. So this is the left pulmonary artery and this is the right pulmonary artery. Clear? But one important thing that you have to know is there is an entity called ligamentum arteriosum. This is nothing but an obliterated part of ductus arteriosus. So in the embryological period, this is also referred to as ductus arteriosus, or in the adult you are going to call it as obliterated part, we are going to call it as ligamentous arteriosus. Clear? Which is going to have the connection with the aorta, obviously. And remember, if they ask you where they have connection, you have to answer left pulmonary artery. But some books do give main pulmonary artery at the bifurcation point, but it's better to tell in exam that it's having connection with the aorta on the left pulmonary artery. So one important nerve that hooks around this ductus arteriosus and the pulmonary artery is the left recurrent laryngeal nerve. Left recurrent laryngeal nerve. It's been long thought that this left recurrent laryngeal nerve can be damaged by the enlarging left atrium. If the left atrium is enlarging above like this recurrent laryngeal nerve can be damaged, which might result in hoarseness of voice. And that is what long time we tend to call it as something called Ortner syndrome, which you have studied already in mitral stenosis because of left enlargement. But a lot of theories and investigations have proved very clearly that it is not the left atrial enlargement that is going to cause the hoarseness of voice. It is that the pulmonary artery enlargement, this left pulmonary artery, typically this pulmonary artery, left pulmonary artery and main pulmonary artery dilatation and enlargement, that is going to damage this left recurrent laryngeal nerve, and they are going to result in hoarseness and Ortner syndrome. Clear? Because what happens in MS itself, there are 2 things that are happening. One is left enlargement. At the same time, because of left enlargement backflow, you are getting pulmonary hypertension also. This pulmonary hypertension will lead to dilation of main pulmonary arteries and left and right pulmonary artery, and this is what is thought to be the reason for Ortner syndrome, and this is the latest concept, and not this. This was the thing that was long thought, but is not the reason for Ortner syndrome, and this is going to be the reason for Ortner syndrome. How we know that this is the reason? Because Ortner syndrome is also seen in not only in MS, it's also seen in conditions that cause pulmonary hypertension, like isolated pulmonary artery hypertension also causes Ortner syndrome. Where in isolated PH, your left atrium will not be even dilated into you. In fact, it will be smaller in size because the blood movement of the left atrium is very less. So even in those conditions, you see Ortner syndrome. Why? That led to the conclusion, this is the modern theory, that Ortner syndrome is due to dilatation of the main pulmonary artery and the left pulmonary artery, not due to the dilation of the left atrium. So this maybe is a very new concept, so you might be needing to know about this. This one applied anatomical aspect of the recurrent laryngeal nerve hooking around the ductus arteriosus or ligamentum arteriosus. Okay, so what are the lymphatics? Lymphatic drainage. Lymphatics wise, I mean, whatever the lymph nodes that supply, I'm not going to be in a lot of concern, especially in medicine at least. But one thing of my concern is that your alveoli has no lymphatic drainage. Alveoli has no lymphatic drainage, which means only up to 22 generations you have lymphatic drainage. The 23rd generation, that is alveoli, doesn't have any lymphatic drainage. Very important point. Clear? At the same time, the drainage, if you ask me, I can tell very fast. It's an intrapulmonary nodes to start with, which becomes bronchopulmonary nodes. Then it becomes tracheobronchial nodes, which then becomes paratracheal nodes, which becomes bronchomediastinal nodes, which then becomes thoracic duct on the left side and right lymphatic duct on the right side. Right lymphatic duct on the right side. So this is the proper drainage, but that point is not important for me. I told you what is important for me, that is alveoli has no lymphatic drainage. So that's the point I want. So fine. So we have finished the lymphatic drainage also. Then what about the nerve supply? Nerve supply is truly and purely autonomic nervous system. It's a visceral organ, so it will be supplied by ANS only. So there are two types of ANS system. One is sympathetics and second is the parasympathetics. How they are going to be supplied is through something called a pulmonary plexus. Pulmonary plexus of nerves, which is going to reach the lungs along the vasculature. It's a specific, the thing about the ANS. ANS doesn't come alone like nerves. They generally tend to come along with the vessels and other somatic nerves. So generally don't enter the organ or something like straight away. So they come accompanying some structure. Here it comes along with the vessels and enter the lungs, and it's called pulmonary plexus. Sympathetic, the most important receptor is beta 2 in the lungs, which typically produces bronchodilation. And parasympathetic, the most important is the M3 receptor, which is going to typically, it's a muscarinic one, so they're going to produce bronchoconstriction. So these are two things that are important. That's why beta 2 agonists produce bronchodilation. Similarly, muscarinic antagonists produces again bronchodilation. So which means your muscarinic antagonists as well as beta 2 agonists can be used as potential therapeutic targets for your bronchodilation in a lot of conditions, including bronchial asthma and COPD. So anyways, these are the importance of the nerve supply to the bronchus, to the lungs. But before going into the histology of the lung, one thing that I really wanted to tell is on the thing called a secondary pulmonary lobule. Secondary pulmonary lobule. So this is a very, very important thing which I want to discuss, because this is considered to be the basic functional unit of the lung. Secondary pulmonary lobule is considered to be the basic functional unit of the lung. Very important point. So why it's called basic functional unit of the lung? Let us see. So let us take one picture. Just give me a moment till I load it. So this is the picture I want to show you. For the secondary pulmonary lobule. Hexagonal structures that you can see here, which you can also call as icosahedral or irregular hexagonal in nature. And this are what the secondary pulmonary lobules are. So you can also see that the secondary pulmonary lobules are going to have a separate septum, which will be referred to as an interlobular septum with a thickness of approximately 0.1 millimeter. And you can see one glistening structure over all this entire lung. So all the secondary pulmonary lobules, the glistening structure is nothing but the visceral pleura. And this visceral pleura is also 0.1 millimeter in thickness. Anyways, These are important CT data because you cannot understand the CT unless and until you know the thickness of all these things and the your secondary pulmonary lobule information. So because this is a basic CT unit also, the secondary pulmonary lobule. That's why it's of paramount importance to understand the secondary pulmonary lobule in a very detailed way. Okay. So now, what are the things that are going to enter into the secondary pulmonary lobule? The first one that enters into the secondary pulmonary lobule, I can call it as something called a lobular bronchiole. This is a lobular bronchiole, and it's going to have a diameter of 1 millimeter or thickness of 1 millimeter. And along with that, you are going to have this pulmonary artery also, which is also going to enter along with the lobular bronchiole, and this pulmonary artery also is going to be somewhere around 1 millimeter in thickness. And the wall thickness of this lobular bronchiole is going to be approximately 0.15 millimeter thick. Remember, the diameter is different, the wall thickness is different. Diameter is 1 millimeter, but the wall thickness is 0.15 millimeter. So this lobular bronchiole and the pulmonary artery is blue here because it carries deoxygenated blood, obviously. So this lobular bronchiole and the pulmonary artery are going to enter the center of the secondary pulmonary lobule, which I cannot show here in the two-dimensional image. Anyways, it's going to enter the center of the secondary pulmonary lobule, and this is going to give rise. This lobular bronchus is further going to divide into another airway divisions. Like for example, in this, it's going to divide into a terminal bronchiole. So approximately how many terminal bronchioles? This is the generation number 16th. You know that. How many terminal bronchioles? Typically, they have 3 to 5 terminal bronchioles in a secondary pulmonary lobule. Okay. Now, this terminal bronchioles are further going to divide into multiple respiratory bronchioles. Multiple respiratory bronchiole. So let us assume this is a respiratory bronchiole. So in respiratory bronchiole, you know, they are going to contribute to generation number 17 to 19 generation. So let us take only one respiratory bronchiole, and you have multiple alveolar ducts. So these are the alveolar ducts which typically contribute to generation number 20 to 20th to 22nd generation. These alveolar ducts are going to form numerous alveoli, which is the 23rd generation. Clear? This one respiratory bronchiole, and along with that, its alveolar duct and the alveoli. This one respiratory bronchiole, along with alveolar duct, its alveolar ducts and the alveoli, is what we typically call it as something called a respiratory unit. This is what we typically call it as a respiratory unit. Otherwise, this is also referred to as something called respiratory acinus or acinus of Loschke. Acinus of Loschke. This is also called as acinus of Loschke, or otherwise referred to as something called a respiratory unit. In a single respiratory unit or an acinus of Loschke, how many alveoli you get? Typically, you have around 2000 to 4000 alveoli in one acinus, and or a respiratory unit, you have approximately 2000 to 4000 alveoli. And whether these alveoli are going to, communicate with each other, yes, they can actually communicate with each other through something called pores of cone. So they have this respiratory pores of cone where an alveoli can communicate with another alveoli through these small pores. At the same time, this particular alveolar duct, let us take this particular alveolar duct along with its associated alveoli, is what we famously called as a primary pulmonary lobule, or simply you can call it as a primary lobule. Even though it is given as a definition, but this does not carry any clinical or anatomical significance. So this is called a primary lobule, alveolar duct with associated alveoli, and a respiratory bronchiole with its associated alveolar ducts along with the alveoli, we call it as a respiratory unit, or we are going to call it as a acinus of Loschke, which contains approximately 2000 to 4000 alveoli. So like this, you are going to have a lot of alveoli, lot of acinus like this, so much of acinus you have in the entire secondary pulmonary lobule. If they ask you how many acinus you are going to have in a secondary pulmonary lobule, is approximately going to be 3 to 30 acini. You are going to approximately have a varying range of 3 to 30 acini. Typically, average they have at least a 20 acini. Usually, a single secondary pulmonary lobule is going to have a 20 acini as an average. And in between, they have something called intralobular septum also, like which separates the acini. So that is all not needed. But anyway, they have intralobular septum also, which can separate each and every acini also. So that this is the basic CT unit of the lung, and this is the basic functional unit of the lung as well. This is the secondary pulmonary lobule. And where are going to be the pulmonary veins? The pulmonary veins are going to originate from the sides of the septum. Here is where your pulmonary veins are going to originate. So these pulmonary veins form finally a single lobular pulmonary vein, so which is going to arise from a single pulmonary lobule. So this is the pulmonary vein. At the same time, the pulmonary vein doesn't only have pulmonary vein, they also have lymphatics in it. The diameter of the pulmonary vein is approximately 0.5 millimeter in diameter. Clear? So they are going to come from the sides along the interlobular septum. So what is the functional significance of this pulmonary veins and probably this interlobular septum? If you take a disease like ILD or any idiopathic pulmonary fibrosis, the first thing to get thickened is this interlobular septum. So this interlobular septum thickening is the reason why you get this honeycombing appearance and this reticular density. So all these things are due to thickening of this and fibrosis of this interlobular septum only. So that is the reason why this is a very important structure. At the same time, whenever there is a left heart failure, your blood will leak back into the left atrium, which will leak back into the pulmonary veins, which is going to cause pulmonary venous congestion. This pulmonary venous congestion will dilate this small pulmonary veins. Once these small pulmonary veins get dilated, you are going to get something called a septal congestion or septal edema. So this is what we refer to as septal edema. It is nothing but edema of the interlobular septum. So this interlobular septal edema is the one that is going to give rise to your Kerley B lines in the X-ray, which is nothing but these are perpendicular lines from the pleural surface due to interlobular septal edema. Clear? So there are a lot of significance about knowing all these things is there. So I told you certain important significance of knowing all this, but the important CT's functional unit of the lung is the secondary pulmonary lobule only. It's carrying so much importance for the radiologist perspective, especially if you want to know the CT anatomy. So for example, the main thing lies in the emphysema aspect. For example, you have an emphysema and you're going to name the emphysema, isn't it? So how can you name the emphysema? Like suppose if it's affecting the central portions predominantly, I'm going to call this emphysema as centrilobular or a centriacinar type of emphysema. Cool. Suppose if I have an emphysema, let us take this secondary pulmonary lobule. I have an emphysema which is going to affect the entire secondary pulmonary lobule. Every area the air space are dilated. I'm going to call it as a pan-acinar emphysema. You know, centrilobular is the most common type, that is associated with smoking. Pan-acinar is associated with alpha-antitrypsin deficiency, but that is not common. Then if you have only this distal portions of the secondary pulmonary lobule are affected with a little on the side, this is referred to as something called a paraseptal or a distal acinar or an irregular type of emphysema. So which means your nomenclature of emphysema is also based on the secondary pulmonary lobule. Even though in pathology they will give differentiation based on where the dilation happens. Suppose if dilation happens only at the terminal bronchiole plus or minus respiratory bronchiole level, you are going to call it as centrilobular. If the entire respiratory unit is dilated, you are going to call it as a pan-acinar type of emphysema, which we'll again discuss in the emphysema topic. But anyway, so in the CT, how we are going to find out centrilobular versus pan-acinar versus distal acinar emphysema is based on the arrangement of the secondary pulmonary lobule only. Let me show one more diagram for you to grasp these things better. So because I'm going to show the CT picture. So you can see here, I mean, these things already I told you, this is the lobular bronchiole and this is going to be the pulmonary artery on the side that is coming along with the lobular bronchiole. And you can see these are the pulmonary veins along with the lymphatics that are going on the side of the alveoli. I mean, on the side of the secondary pulmonary lobule. And this is the interlobular septum that you are seeing. Interlobular septa typically 0.1 millimeter thick, and this is the visceral pleura that is covering the secondary pulmonary lobule. So this is the visceral pleura that is covering the secondary pulmonary lobule, and this is the interlobular septum that you can see. Clear? And here the bronchial wall thickness, as I mentioned, it is 0.15 millimeters. All these things data we have given already, so it's not something new. Let us come back to this. You can see this is one secondary pulmonary lobule in CT, and you can see a typical structures. These are nothing but the pulmonary artery and the bronchioles, lobular bronchiole and the pulmonary artery that's going in the center of the secondary pulmonary lobule. So you can see these are the interlobular septum. So you can see this. These are the interlobular septum. So these are some things that are very important to understand. At the same time, I also wanted to tell about the bronchiole to or bronchus to artery ratio. So there is something called bronchus to artery ratio, which is really important to understand. So let me put an artery over here, bronchus maybe in black color. So let me put this a bronchus, and you can put an artery. So this is an artery, and this is a bronchus. So bronchus. So what is the bronchus to artery ratio? As I told you here, the bronchus to artery ratio, the artery will be always bigger. So the bronchus to artery ratio must be somewhere around 0.65 to 0.7. Suppose if the ratio is more than 1, this is what we call it as a bronchiectasis. Typically, bronchiectasis is a disease that affects the medium-sized bronchi, not the typical smaller bronchioles of the respiratory unit. So it's going to affect the medium-sized bronchi, typically the segmental or a subsegmental bronchus that's supplying the bronchopulmonary segment, or a little bit later than that, the third or fourth generation bronchus is the one that is affected in the bronchiectasis disease. If the ratio of the artery to bronchus, bronchus to artery is more than 1, typically that is seen in bronchiectasis. And now what will happen is the bronchus actually will become larger than the artery. Clear? The bronchus is going to become larger than the artery. And this is what we called as something called a signet ring sign. Normally itself, physiologically itself, broncho-arterial ratio will increase with age. That is different. But anyway, this is typical of a bronchiectasis as far as exams is concerned. So this is the normal ratio. If it's more than 1, it is representative of a bronchiectasis. Again, a very important point. Again, for a basic CT anatomy. Fine, let us see the interstitium of the lung. What are the importance of the interstitium of the lung? So what are things you are going to see in the interstitium? Okay. So interstitium can be divided into many types. The basic types of interstitium, we call it as something called axial fiber system, and you have a peripheral fiber system. The axial fiber system, again, it's divided into 2 types. One is called a peribronchovascular interstitium, and second one you have a centrilobular interstitium. Then peripheral fiber system, you have 2 types again. One is called a subpleural interstitium, and second one you have something called an interlobular septum. So we saw about this interlobular septum and subpleural thing also already we saw in a decent way. So suppose if you take a lung, let us take this the right lung, and your vessels are going to enter in this area. So your connective tissue also will come along with this area, and they go like this along with the vessels and the bronchus. So this is what we refer to as something called a peribronchovascular interstitium. Peribronchovascular interstitium. And finally, you are going to have multiple secondary pulmonary lobules, which are the basic functional unit of the lung. The septum that is connecting, that is surrounding the secondary pulmonary lobules connective tissue. This is what we call it as something called interlobular septum. Interlobular septum. And apart from that, you also have this subpleural interstitium. You can see here, and we can remember these interstitiums are very important, especially when you are seeing the CT anatomy of ILD, because these are the conditions that are going to be thickened in interstitial lung diseases, and especially in conditions that are going to cause fibrosis like IPF. So that's why I'm telling you all these things. So this is what we called as something called a subpleural interstitium. Clear? And these things that are coming into the secondary pulmonary lobule like this. Clear? So this septum is what we are going to call it as something called a centrilobular interstitium. Centrilobular interstitium. Apart from that, they also form the backbone for something called intralobular interstitium also, which I told you already. Intralobular septum is also there. They contribute intralobular, but I'm not going to tell about that. I told you about the 4 classical interstitium, that is peribronchovascular, subpleural, interlobular and centrilobular. Apart from that, you have intralobular interstitium also. But anyway, these are the most important types of interstitium that you are going to ever get. And finally, we are moving on to the histological segments of the lung. So we are moving on to the lung histology. From histological perspective, what is important? So let us see certain things in a table. So this is something which has to be understood in table form. So let us put a table. Let us start from the nasal cavity first. Then you have nasopharynx next. Then you have a larynx. Then a trachea. Then you are going to get a bronchus, small and large bronchus. Initially you have a large bronchus, then you have a small bronchus. Then bronchioles, because we're not going to see the alveoli. So bronchioles, you have regular bronchioles, you have terminal bronchioles, and you have something called respiratory bronchioles. So these are the different bronchioles you have. So let us see in a very easy way. I'm not going to make a big fuss. So let us see how the histological segments are arranged, because these are the areas where you're going to commonly make mistakes in exam. So what are the histological segments? The first one is the epithelium. Epithelium wise, let me put like this. Till you get into the bronchus, till the entire bronchus is there, let me put a box. From here till your entire bronchus, let me put, you're going to have only one type of epithelium. That kind of epithelium is what we refer to as pseudo-stratified columnar epithelium, ciliated columnar epithelium, pseudo-stratified ciliated columnar epithelium. Remember, the ciliation is very important. The cilia is the one that is going to have this mucociliary escalator action, which is going to like push away the dust and the microbes that enter inadvertently into the respiratory tract. So they have very, very important function. And in the respiratory bronchioles, and in the bronchioles, typically in the regular bronchioles, you're going to have again a pseudo-stratified ciliated columnar epithelium. And in the terminal bronchioles, you have simple ciliated columnar epithelium, and in respiratory bronchioles you are going to have simple ciliated cuboidal epithelium. So this is about the bronchioles. So till you have the regular bronchioles, you are going to have this ciliated columnar, pseudo-stratified ciliated columnar epithelium only. After that you have simple ciliated columnar, then you have simple ciliated cuboidal epithelium. Remember, this is one question which is often asked in exam, and many times as a one-liner you make a mistake, because it's not the clinical scenario questions that often gives your bad results. It's these kind of questions which you consider it as very easy and you don't answer it in exam 100%. There is no doubt about that. Only smart people will write all these things in the separate notebook and they're going to read it at the end and they're going to answer, because these are something not going to test your knowledge, but they're going to test your memory. Anyway, I know it's not important, but still exam wise it is important. Then you have the goblet cells in the glands, goblet cells and the glands. You're going to see a lot of goblet cells in the glands till you reach the trachea. It's very abundant. In the bronchi, it is present, the large bronchus. As you move apart, it's going to reduce and you're not going to see any goblet cells or glands in the terminal bronchiole or the respiratory bronchiole. So which means the goblets and the glands, they progressively decrease over time. The decline starts in the bronchi level itself. The decline is going to start at the bronchi level itself. These are the areas, but here typically they are absent in the terminal bronchiole and the respiratory bronchiole. So this is what you're going to see. Then what about the cartilage? Cartilage is, like nasal cavity, except the ALR part, you don't have a cartilage. Nasopharynx, again, you don't have a cartilage. Larynx, you get the complex cartilage. In trachea, they are arranged in the form of C-shaped rings. In the bronchus, the large bronchus, they will be present as irregular plates or irregular rings, whereas in small bronchi, they will be found as plates and islands of cartilage will be there. Whereas the moment you enter this regular bronchiole, terminal respiratory bronchiole, you don't have this cartilage support at all. It's a very important respiratory unit, and the respiratory zone doesn't have any cartilage support, which is again a very important point. And these plates and islands, all these things are very routine questions from histological section. Not very high yield, but still not very low yield also. Somewhere in between, you have to know that. Then you know the smooth muscles zone, and again there are no smooth muscles in this area, but in trachea you can see the smooth muscles in the posterior zone. The larynx, still the larynx I can tell no smooth muscle. The trachea, you are going to have smooth muscles in the posterior, spanning the open ends of the C-shaped cartilage that you see, that C rings you see. So typically present in the posterior zone, and here everywhere you will see very good amount of smooth muscles, and you can see everywhere you have a good amount of smooth muscle, which typically going to form crisscrossing spiral fibers, crisscrossing spiral bundles and fibers. So this is how like crisscrossing, like they will be arranged. So abundant smooth muscles will be there from the moment you start from the bronchi, but initially you don't have that much of smooth muscles. This I told you already. Then elastic fibers. Typically, again, you don't have any elastic fibers in the nasal cavity, but you do have some amount of elastic fibers till the trachea. And the moment you enter the bronchus, as you move more and more distally, the elastic fibers are going to keep on increasing, which means elastic fibers again will increase as you move distally. Okay, fine. So these are the very important. Actually, I tried to tell it in a table. So the most important aspect will be the epithelium part that you have to know. Then probably the cartilage, smooth muscle, and the elastic fibers part. Again, this is very important. Remember, the cartilage initially more, later on it decreases. Smooth muscles and elastic fibers initially less, later on it keeps increasing. So this is how I tend to remember this. And that plates and islands in small bronchus, and your irregular rings in large bronchus, and C-shaped rings in trachea, all these things are really important to know. Where all these things have been exam questions many times. So please be very, very careful. These are very simple things, but you often make a mistake. Then you have two types of pneumocytes. One is called a type 1 pneumocyte, and second one is a type 2 pneumocyte. So what are these two types of pneumocytes? So type 1 pneumocytes are nothing but these are squamous cells, thin squamous cells that are going to line the alveoli. Type 2 pneumocytes are cuboidal cells. These are cuboidal alveolar cells. So there are a lot of difference between them. And remember, type 1 cells contribute to 95% of the total alveolar area. Type 2 cells are going to contribute only 5% of the total alveolar area. So don't get fooled by this. Even though they contribute only 5% of the total alveolar area, they are the most abundant cells. Type 2 are the most abundant cells, which means they are going to form 60% of the total number of cells. 60% of the total number of cells is going to be contributed by this type 2 pneumocytes only. Clear? At the same time, these type 1 pneumocytes are connected to each other by tight junctions. Type 1 pneumocytes are connected to each other by this particular tight junctions, And these are the ones along with the endothelium. This is the capillary, pulmonary capillary endothelium. And you have a basement membrane in between. Base membrane always must be pink according to me. So this is the base membrane. And you can clearly see this type 1 pneumocytes with tight junctions along with the capillary system of the base membrane is the one that are going to form something called the blood-air barrier. Blood-air barrier. And very important fact is they cannot proliferate. They cannot proliferate. They don't have any proliferating function. They are end cells. That's all. At the same time, there are two drugs that are very commonly asked. One is called bleomycin and amiodarone. They actually damage the lungs and cause pulmonary fibrosis by damaging type 1 pneumocytes only. This is again very multiple times asked question. They are going to damage the lungs and they cause pulmonary fibrosis by damaging the type 1 pneumocytes, bleomycin and amiodarone. Now going to the type 2. Type 2, I told you, even though they are 5% of the, they are only contributing 5% of the alveolar area, they are the most abundant and contributing 60% of the total number of cells you have. The number, sheer number, if you take 60% of the cells is type 2 pneumocytes only. And typically they have proliferative function. So which means they can proliferate. They can proliferate into both type 1 as well as type 2 pneumocytes during times of damage. Whenever the lung is damaged, this cells can proliferate. This type 2 pneumocytes can proliferate into either a type 1 pneumocyte or a type 2 pneumocyte, both. But like how they form a blood-air barrier. The formation of the blood-air barrier is the main function of a type 1 pneumocyte. Similarly, the main function of a type 2 pneumocyte is formation of the surfactant. Surfactant. They synthesize, they store and they secrete the surfactant. Because, and this surfactant can be seen stored in this type 2 pneumocytes in both electron microscope as well as in the light microscope in high power by their characteristic structure called lamellar bodies. They have these lamellar bodies within them, clear, which store the surfactant. So surfactant typically is composed of, first let us see the composition of the surfactant. Surfactant is typically composed of, phospholipids, 90%, and you have proteins up to 10%. So remaining 10% will be contributed by proteins. The protein part, you know, which is very important, these are surfactant proteins A, B, C, and D. So these are the proteins that are present in the surfactant. Similarly, the phospholipids that are present in the surfactant, two types of phospholipids are there. One is called DPPC, otherwise referred to as lecithin. You know what is DPPC? This is called dipalmitoyl phosphatidyl choline. That is the one that is going to contribute to almost majority of the phospholipid in the surfactant. The minority is contributed by something called phosphatidyl glycerol. Phosphatidyl glycerol. You know the function of the surfactant. The functions of the surfactant is to reduce the surface tension. Surface tension is because your lungs have a small layer of water coating here. You know, this water is going to create a surface tension, which this surface tension is trying to constantly collapse the alveoli. So you might ask me, if the water is there to collapse the alveoli, why you should keep water? You can have driven water off, isn't it? During evolution, you have evolution, you have 4.5 billion of evolution going on. Humans are the most advanced. They can't eliminate this water or what? So why they keep that water? To collapse the alveoli? No, they keep that water because the water here is really, really important, because your oxygen can diffuse by dissolving in water only. So water is an excellent solvent here. So remember, there is no other beautiful solvent in the universe like water. It mixes with everything except for hydrophobic substances. Whatever you mix, it will mix with water. That is the reason, that's the basis of life in earth itself, the water, the necessary ingredient, because it is a solvent. It's an excellent solvent for oxygen as well. And little amount of water is very important. Even lot of amount of water again will impair the diffusion. A small coating of water there is actually very, very beneficial to dissolve oxygen and to push on the other side, which means they are going to enter into the pulmonary capillaries on the other side. So anyway, one of the side effects of that comes along with the water, which is a beautiful solvent, is the surface tension, and it's going to collapse the alveoli. To prevent that only, you have that surfactant. Even though there is a surfactant, but little amount of surface tension will still be there, which we'll see later on in the physiology section. Do you understand? So without this surfactant, the surface tension will become too much, which means it's trying to collapse the alveoli so much so that it will need a great deal of force to expand the alveoli because they're trying to collapse more and more. So you need a great deal of work and energy to expand this alveoli and to breathe in. So that is the reason why loss of surfactant will result in a poorly compliant lung. Because why poorly compliant? Because you need a lot of energy to expand and will not still expand. The surface tension will keep trying to collapse the lung back. So don't underestimate the surface tension. Again, surface tension is something which can even topple the boats. It can topple an entire ship like Titanic. It is the reason why your ants, like walk in water. It is the reason why your leaves float in water, and it's also the reason why a big boat floats in water. All is due to the surface tension. Surface tension is something that is formed on the air-water interface, clear, only on the surface of the water. So it's not something joke or something. The surface tension is sometimes can become so massive that you can have a complete collapse of the alveoli. So which we'll discuss later on in a disease called ARDS. Anyway, to reduce that surface tension only, you have this surfactant. Clear? Typically, the surfactant synthesis starts around 25 to 27 weeks of life itself, in the fetal life itself, but the maturity, the quality of the surfactant, I'm not talking the quantity, the quality of the surfactant will be adequate. The maturity of the surfactant will reach 35 years, around 35 weeks of age. So that is why the infant that is born preterm, before 34 weeks, we have to give steroids for lung maturity. What do you mean by lung maturity? You give steroids, improve the production and the quality of surfactant, because up to 35 weeks, the quality as well as the quantity might be a little bit poor. That's why you push a steroid like betamethasone or dexamethasone to improve the quality of surfactant, the production of surfactant. So that's what we are going to see now. So the moment you call about the surfactant, who is going to increase the production? So surfactant production will be increased with steroids administration. This is the basic principle of why you give this steroids for fetal lung maturity in OBG. At the same time, this clearance of the surfactant is done by the macrophages. What macrophages? These are called alveolar macrophages, which is a part of reticuloendothelial system. And who's going to stimulate these macrophages to clear the surfactant? That is GM-CSF. Very important point. GM-CSF is the one that pushes the alveolar macrophage, that stimulates the alveolar macrophages to take up the surfactant and to destroy them and to clear the surfactant. Suppose if you have a deficiency of GM-CSF, the surfactant clearance may not happen and the surfactant may not clear. Instead, they might accumulate in the lung and the alveoli, which might result in a disease called pulmonary alveolar proteinosis, PAP. This PAP has a lot of causes, but one of the important causes is deficiency of GM-CSF. That's a very rare cause. A lot of other causes are there. Even acute silicosis also, massive silicosis also can cause. Sudden acute massive silicosis also can cause this pulmonary alveolar proteinosis. This is secondary pulmonary alveolar proteinosis. But primary pulmonary alveolar proteinosis, one of the important causes are deficiency of this GM-CSF, which is important for clearing the surfactant by alveolar macrophages. Clear? So let us see the lamellar bodies now. You can see these are the lamellar bodies. You can see here, these are nothing but type 2 pneumocytes. Remaining are type 1 pneumocytes which I have shown. So these are the lamellar bodies which are type 2 pneumocytes. Clear? So this area, this is the one that is called type 1 pneumocytes. These are the type 1 pneumocytes. And this, you can see here the cilia. You can see the cilia. These are nothing but a bronchiolar epithelium. Bronchiolar epithelium, which is containing ciliated columnar epithelial cells. You can see these are ciliated columnar epithelial cells of a bronchiole. Here in this condition, this is nothing but a respiratory bronchiole. Clear? And also you can see these red arrows are non-ciliated columnar epithelial cells, or these are non-ciliated bronchiolar secretory cells. They don't have cilia. You can see they don't have cilia. Bronchiolar secretory cells, otherwise referred to as something called Clara cells. So these are some of the important histological features of the lung biopsy. You can see, and this very common question in exam. So you can get this particular thing. So these are nothing but these lamellar bodies that are typically seen in the type 2 pneumocytes. Very important again. So now let us move on to the important embryological aspects of the lung. Important embryological aspects of the lung. So what are the important embryological aspects? So embryological aspects of the lung can be divided into your embryonic period, pseudoglandular period, canalicular period, saccular period, and alveolar period. So when the moment you call about the these periods, first of all, it's to define the weeks. Obviously, you know the first 6 weeks is going to be on the embryonic period. So this is the first 6 weeks, typically on the embryonic period. You can see what are the things that develop. So during this embryonic period, it is typically the trachea and the bronchi, especially the mainstem bronchi. So these are the ones that are going to be developed in the embryonic period. Even before that, where this trachea and all these things starts from, this trachea instead, it starts from something called a lung bud. The entire lung process starts from a lung bud, which originates around 3rd week of gestation. And where this lung bud originates from, this lung bud is going to originate from this entity called foregut endoderm. Foregut endoderm. So that is the reason why this lungs are considered as a part of the foregut. Sometimes you will be confused a lot in a particular disease called a bronchial carcinoid or a pulmonary carcinoid, where they would have given this bronchial and pulmonary carcinoid as an example of a foregut carcinoid. You might be thinking, going nuts, thinking, I mean, how come a lung can come in a foregut structure? In anatomy, we have studied only esophagus, stomach, and all these are foregut structures. It's all about embryology, where this lung bud typically originates from the foregut endoderm. So that is why lung embryologically is considered as a part of the foregut, but even though as it becomes a separate structure, so don't confuse with them. So this might be useful when you're studying a carcinoid. That's it. Apart from that, there is no use. So this embryonic period. So whenever there's problem with this embryonic period, error will lead to formation of something called tracheoesophageal fistula, which will be dealing in great detail when you are discussing the GA section. And you can also get this bronchopulmonary sequestration also. So these are the two disorders that are associated with problems in the embryonic period. So next, we can see about the problems in the next disorder called the pseudoglandular period. Pseudoglandular period typically is a period that is around 6 to 16 weeks of age. So in this condition, you are going to, in the pseudoglandular period, you are going to develop the bronchioles and the terminal bronchioles, typically here. So even though there is some mismatch over here. So typically you are going to generate the bronchioles and the terminal bronchioles. So this is what is going to develop in the pseudoglandular period. And the errors in the pseudoglandular period will be leading to one important congenital disease called bronchogenic cyst. This is due to errors in the pseudoglandular period most often. At the same time, the pseudoglandular period, apart from getting a bronchial and a terminal bronchiole, your type 2 pneumocytes will appear. I'm not telling they will be fully developed. They will just appear here. And the lung capillaries also tend to appear. They're not fully developed, type 2 pneumocytes, but they tend to appear at this stage during the pseudoglandular period. Then you have something called a canalicular period, so which lasts from 16 to 26 weeks. So during the canalicular period, the most important event that is going to happen is the development of the respiratory bronchioles. So next generation, you are moving to the next. So you are going to generate the respiratory bronchioles, which contribute to typically the generation 17 to 19. And the errors in the canalicular period might result in few diseases like pulmonary hypoplasia or respiratory distress syndrome of the newborn, otherwise called as hyaline membrane disease. We'll see why. Because during this period only, your primitive alveoli will form. During this period only, your primitive alveoli is going to form, and they are going to create type 1 pneumocytes on the blood-air barrier also during the canalicular period only. That's why this period is very important. At the same time, poor development of surfactant might result in respiratory distress syndrome. Why typically I'm telling this respiratory distress and hyaline membrane disease of the newborn in this particular period? Because this 16 to 26 weeks mark is the time where your surfactant production will start. So typically if someone asks you when the surfactant production starts, surfactant production begins at approximately 20 to 22 weeks. This is the time where the surfactant production begins, which is typically in the canalicular period. That is the reason why any problem in the surfactant production during this period will result in respiratory distress syndrome and hyaline disease of the newborn. And but remember, even though the production starts at 20 to 22 weeks, I told you, but the maturity of the surfactant will be taking around 35 weeks. This means the complete quality and the full quantity of the surfactant will reach its peak only by 35 weeks of gestation. That is the reason any fetus that is born before this period has to be given with, empirical steroids for fetal lung maturity. And you have a sacchalar period. Typically, the sacchalar period happens from week number 26 up to birth. We are going to form alveolar ducts and a very immature alveoli, not a very fully functional alveoli, but an immature alveoli you are going to get, thin-walled alveoli. And there are no much importance of this sacchalar period. And in alveolar period, typically happens till 8 years of age, after birth till 8 years of age, where they form definitive alveoli. And they also form mature. Definitive alveoli means they will be separated by secondary septum. They will be separated by secondary septa. That's what we call definitive alveoli. It will be thick-walled mostly. And also you get this mature type 2 pneumocyte. The final full maturation of the type 2 pneumocytes will take approximately around 8 years of life. And during this period, again, there are not going to be that much significant. So, you're not going to get any much disorders of lung, congenital disorders. So, the first 3 disorders are very important to understand. At the same time, how many alveoli are present at birth? Typically, only 50% of the adult alveoli will be there at birth. 50% of the adult alveoli will be at birth, which means what is the total number of adult alveoli if they ask you? Answer is 300 million alveoli. So remember, it takes a great deal to destroy this 300 million alveoli by smoking. That's what you do in COPD and chronic bronchitis. You destroy this lot of alveoli by smoking, and it takes really a great deal. You have to smoke too much to destroy this 300 million alveoli. You have so much of alveoli with so much of surface area is there. So take care of your lung. So don't smoke. Clear. So these are some of the embryological aspects, and please remember this 5 phases of the embryonic period. The embryology of the lung. That is the embryonic period, pseudoglandular period, canaliculi period, sacchalar period, and final alveolar period. So then we can move on to the disorders. So what are the disorders that you see because of this abnormal embryology? So because of this abnormal embryology, you are going to give result to certain disorders. So these are called as something called congenital pulmonary malformations. Congenital pulmonary malformations. As said, this congenital pulmonary malformations has a lot of types are there. The first type we called as something called CPAM. That's called congenital pulmonary airway malformation. It's totally because of airway malformations, not parenchymal. So congenital pulmonary airway malformations. Previously, this is also referred to as CCAM, that is called congenital cystic adenoid malformation. But currently, we stick on to the term congenital pulmonary airway malformation. Then you have another disease called congenital lobar emphysema, that's called CLE. Then you have another disease called bronchogenic cyst, called as BC. And you also have another disease called bronchopulmonary sequestration, that's called BPS. Clear? The bronchopulmonary sequestration is also referred to as something called an accessory lung. So we are going to discuss all these disorders one by one. So first disorder I'm going to discuss is on the CPAM. CPAM is nothing but congenital pulmonary airway malformation. So let us put CPAM, congenital pulmonary airway malformation. So what do you mean by this congenital pulmonary airway malformation? It's an airway malformation. It's not a parenchymal or an alveolar thing. It's an airway malformation. So let us see what are the things that's going to happen. So number one, there is no sex predilection, which means it can happen in both female child as well as male child in equal proportions. At the same time, it will be limited to only one lobe, one particular lobe. That's it. Only one single particular lobe. That's what it's going to be. And you have a lot of different types of this CPAM. So let us see what could be the types of CPAM. I can show you here with the help of an image. So these are some of the types of CPAM. You have type 0, that is tracheobronchial. You have type 1, that is bronchial. You have type 2, that is bronchiolar. And type 3, it happens at the alveolar duct. And type 4 is very rare, it happens at the distal acinar level. Clear? All are in the airways typically. Distal acinar may be occurring at the alveoli level, but still it's very, very rare entity. So first, type 0 tracheobronchial. Remember, if you ask me which is the most common, the type 1 bronchial is supposed to be the most common. And this type 2 bronchular is supposed to be the second most common. And this type 0 tracheobronchial is going to be the least common. Clear? And at the same time, they form some cysts. Usually this congenital pulmonary malformation forms some cystic kind of structures, usually. So if they ask you which is the one that's going to produce the smallest cyst, that's a very common question in exam. So that is type 3 alveolar duct. So this is what is going to form a cyst of less than 0.2 centimeter, which is going to be the most smallest ever cyst formed by a CPAM. So this also is a very important question, smallest cyst. And next important thing, which are the two types that are going to be associated with the malignant transformation? Only two. That is type 1. Type 1 will be associated with the malignant transformation. Similarly, type 4 can be associated with the malignant transformation. So what malignancy? Usually they will have a bronchiolo-alveolar type of malignancy. That's what you will get. And in type 4, you might get something called a pleuropulmonary blastoma. Pleuropulmonary blastoma. Remember, these are some of the exam questions. Remember, all the types are very important. In that type, 1 is supposed to be the most common and type 0 is supposed to be the least common. At the same time, only 2 will be associated with malignant transformation, that is type 1, which is such as a risk of forming bronchiolo-alveolar carcinoma, and type 4, which is the risk of forming pleuropulmonary blastoma. And the cyst size may be variable in many diseases, but the most smallest cyst size you are going to get in type 3 alveolar duct area only. So that kind of CPAM is going to have a smallest cyst. If you ask me about the clinical features, I'll tell you all the congenital pulmonary malformations tend to have common clinical features. Remember, there are two possibilities. They can be asymptomatic at birth or they can be symptomatic at birth. So let me tell you a common clinical feature for all this. I'm not going to tell this repeatedly again and again. So asymptomatic at birth, which means they can become symptomatic later in life. When they become symptomatic depends on the type of malformation. So they may become symptomatic later in life, but they might be asymptomatic or they might be symptomatic at birth. If they are symptomatic at birth, it depends on size, especially if the size is very big, then the child may be symptomatic at birth itself. Typically, they can come with shortness of breath, severe cyanosis, or even they can even present with hydrops, because these are present like mass lesions. If they are very, very big, they can impede the venous return to the heart, which means since the venous return is going to stop, they are going to cause venous congestion and edema all over the body, and that is what we refer to as fetal hydrops. So if the size is very big, they can be very, very symptomatic in utero or in birth itself or at birth itself. If they are asymptomatic at birth, they will become symptomatic later in life, and when they will become symptomatic depends on what is the type of malformation you encounter. Usually, the most important symptom that they are going to develop is pneumonia and lung infections. Very likely it will be chronic, recurrent and refractory to medications. This is the single most important point that is important to diagnose a congenital pulmonary disease. Clear? Typically, they will have a pneumonia, long-standing infection that is not resolving at all, chronic, recurrent, and it will be refractory to your treatment. It will come again and again and again. So that's a number one clue for your congenital pulmonary infection. Second thing, they can develop other disorders like shortness of breath, which will be typically progressive in nature, which might limit their quality of life also. So these are the usual things that they are going to see. And this is nothing like different. This is also going to present in the same way. Clear? So usually I told you they can be asymptomatic or symptomatic. Symptomatic, we know already how they're going to be symptomatic. If they're asymptomatic, I told you when they'll become symptomatic depends typically on the type of malformation. In CPAM, they become symptomatic at approximately 2 to 13 years of age. It's a wide number, but still they become asymptomatic but a variable age of 2 to 13 years of age. And treatment is very importantly surgical resection, especially if the patient is symptomatic. Suppose the patient is asymptomatic, you can wait and observe, and you can do serial CTs and serial imagings, and you can watch how this CPAM is going to behave. But anyways, all symptomatic patients has to go for surgical resection. This is what about your congenital pulmonary airway malformation. And you have a next disorder called congenital lobar emphysema. So what do you mean by congenital lobar emphysema? So there is one part of the lung that is going to get emphysematous, which is going to become hyperlucent. Why I told you this is because this area is going to get hyperinflated very commonly in the child, and it's going to be hyperlucent in chest X-ray. Hyperlucent in chest X-ray, and this is nothing but the left upper lobe. This is the commonest site for a congenital lobar emphysema. Like CPAM, unlike CPAM, this has a sex predilection where male children are very commonly affected than female children. Clear? Again, symptoms depend on, like what is the size and all those things. Symptoms, whatever I told you is going to apply here also, there is no doubt. But very importantly, CPAM will not have any cardiac anomalies associated, but this have very commonly associated cardiac anomalies. Associated cardiac anomalies are extremely common. Associated cardiac anomalies are extremely common with your congenital lobar emphysema. Then you have a bronchogenic cyst, and treatment is resection if it's symptomatic. Again, surgical resection if they are symptomatic. Asymptomatic, you can wait and you can give a conservative management in asymptomatic children. Bronchogenic cyst, there is no particular location. They can be anywhere in the respiratory tract from the trachea till the alveoli. Anywhere it can happen, this bronchogenic cyst. And again, since symptoms depend on the size, whether they present at birth or whether they don't present at birth, but very commonly they present in the second decade. Second decade tends to be the most common presenting period. And most often they will present with compressive features, compressive symptoms than any other symptom. They compress the esophagus causing dysphagia, trachea causing stridor. So majority of the time they will have this compressive features. That is the one that is going to, bring the patient to the hospital. And treatment is surgical resection. Almost all cases will be resected because anyway they will enlarge and they are going to definitely compress on the structures and they are going to result in some symptoms or not. So definitely surgical resection is indicated in bronchogenic cyst. And finally, you have one of the most important disorders called bronchopulmonary sequestration, otherwise referred to as accessory lung. Remember, this is a characteristic example of how they are going to present with the chronic long-standing pneumonia. Very, very classically, this bronchopulmonary sequestration is going to present with long-standing pneumonia. Very, very important. Very chronic, refractory, recurrent pneumonia. And typically, again, this is very common in this male children compared to the female children. And what do you mean by a bronchopulmonary sequestration? You have an area of the lung that is totally disconnected from the rest of the lung. It's a lung tissue only. It's not, I'm not telling it's not a lung tissue, but that part of the lung tissue in the thorax is completely disconnected from the other area, other native lung, which means they are not connected to the airways. They are not connected to the blood supply. They are not connected to the native lung by any means. They are separate and they have their own blood supply and they're not connected to the native lungs airways. There is no, airways that is communicating with this sequestered lung. So which means it's a completely separate portion of the lung that is completely disconnected from your native lung. So there are two types of bronchopulmonary sequestration. One is called an intralobar sequestration, and second one you have something called extralobar sequestration. In both these sequestration, the most important, let me draw the diagram first. If you have an intralobar sequestration, if you take this the left lung, if it's an intralobar sequestration, there will be a sequestered part of the lung. Let us assume this is the sequestered portion of the lung that will be present within the native lung. I mean, this is the disconnected part only, but they will be present within this original lung, native lung. So this is the sequestered lung. Clear? And second one, if you take extralobar sequestration, in extralobar sequestration, the sequestered lung, that's a disconnected part of the lung, will be located separately outside. This is the sequestered part of the lung. So very commonly where they will be located is between the left lung and the diaphragm for extralobar. You can see that's what I draw. The usual site for this extralobar sequestration is between the left lower lobe, and the diaphragm. So this is where you are going to get the sequestered lung. So in intralobar sequestration, very commonly you will get in the lower lobe or either lung, any one lung. Usually, typically the left lung is what the usual area is, but you can get in the right lung also, but very commonly in the lower lobe. But what defines, how can you diagnose this? Is by its arterial supply. Remember, it's arterial supply. It's not going to be bronchial artery. It's not going to be pulmonary artery. It's not going to be pulmonary vein. It's not going to be bronchial vein. It is the aorta that is going to supply this sequestered lung. This is the gold standard for diagnosis as well. So if you find out that aorta is supplying the sequestered part, damn, boom, the diagnosis is done. This is a bronchopulmonary sequestration. So that is the reason, no matter what is the type of sequestration, CT angiogram or any form of angiogram is going to be the gold standard for diagnosis of the sequestered portion of the lung. But vascular supply is the key. That's the magic. That's what is going to give the diagnosis. At the same time, which is going to be the most common? Intralobar, extralobar. Intralobar is going to be the most common, contributing 75% of the cases, and extralobar is going to be 25% only. And remember, this extralobar sequestration is going to present in the neonatal period itself, whereas this intralobar sequestration typically presents with presents in older children and adults as a long-standing pulmonary infection. That's how they come. The long-standing pneumonia, that's the usual, like presenting feature of intralobar sequestration, whereas in neonates, they often present with, because it's a early presentation, they're going to come with respiratory distress and feeding difficulties. This is how an extralobar sequestration will be presenting. Clear? And typically, again, you have to know the venous drainage also. The venous drainage of your intralobar sequestration is through the pulmonary veins, whereas the venous drainage of extralobar sequestration is going to be the systemic veins, like for example IVC, azygos, like that. And to be honest, again, anomalies, associated anomalies are very uncommon, rare. If you ask your associated anomalies like cardiac, any other associated anomalies are very rare with intralobar sequestration. But extralobar sequestration very commonly have a lot of associated anomalies. Associated anomalies, like for example, you might have a congenital lobar emphysema, you might have a bronchogenic cyst, you might have a type 2 CPAM, which is the second most common type. Then you can have pulmonary hypoplasia. Then you can have a congenital diaphragmatic hernia, CDH. Congenital diaphragmatic hernia. Then you can also have a cardiovascular anomalies like VSD. So a lot of anomalies you might get in these patients, extralobar sequestration. But intralobar, you typically don't get any anomalies. Maybe very mild anomalies can be there, but you generally don't get any anomalies. And this intralobar sequestered mass typically comes like a solid and fibrotic mass. That's the appearance typically is seen in gross pathology. Whereas this extralobar sequestration is going to have a solid and a spongy mass. And some minor things we will see now. This extralobar sequestration has its own pleural covering. So they have this own pleural covering. They have a separate and own pleural covering. But this intralobar sequestration doesn't have any own pleural covering. The pleural covering will be along with the native lung. So there is no separate pleural covering that you see with the intralobar sequestration. But extralobar sequestration is going to have a separate own pleural covering, which I told you already. And typically aeration, like if we see aeration will be possible or not. Aeration is possible in intralobar sequestration because you have a lot of alveoli, surrounding alveoli. And you know that this alveoli are going to have something called the pores of cone. This pores of cone can transmit the air into this sequestered lung in intralobar sequestration. So aeration is possible. But this lung, aeration is impossible because it has its own separate pleural covering. There is no aeration of this sequestered part, which means air cannot move into the sequestered lung because it has its own pleural covering and it separately exists out of the native lung. So you cannot get any aeration in this. So these are the basic differences between an intralobar sequestration and an extralobar sequestration. But remember, Treatment wise, again, they will require some surgical intervention only. Most of the cases has to be removed. Like whether they are symptomatic or asymptomatic doesn't matter. Some time or the other, they'll become symptomatic. So it's always better to remove by surgical resection. Even though certain guidelines still you can observe for some time, but I don't think there is much role for observation. It's better to always resect this sequestered part because it's going to definitely cause some problem or the other later in the life because it's going to cause recurrent infections, pneumonia, or you might die of a pneumonia and sepsis because of some colonization of some fulminant organisms. So it's better to remove that all right, most of the time. And I told you again, the gold standard for diagnosis is you have to prove that you have that sequestered part, is supplied by the aorta. So that is what is going to be the gold standard for diagnosis. Now let us see some images of this congenital pulmonary airway malformations and related congenital abnormalities. So the most important of them is going to be the bronchopulmonary sequestration. That's going to be your exam question. So you can see this patient is having some mass like appearance. We don't know really what is this mass means here. And this patient will typically have a history of chronic long-standing pneumonia, and that is refractive treatment. And you don't know really what is this. So how you are going to diagnose? Do a CT angiogram. So this is an image of a CT angiogram where you can clearly see this is the aorta that is supplying the mass, which is clearly proving that it is a bronchopulmonary sequestration. This is a typical example of an intralobar sequestration, which you know already. This is a typical example of a intralobar sequestration. You can see that is supplied by the aorta. Clear? And you can see this is one example of an extralobar sequestration where you can see a mass-like appearance that is present between the left lower lobe and the diaphragm. So this is an example of an extralobar sequestration. Now you can see another example of CPAM. So this is a typical example of a congenital pulmonary airway malformation where you can see, a structure which is actually pushing the mediastinum to the other side, the structures to the other side. You can see the CT of the same child also, which typically shows a CPAM. This is the congenital pulmonary airway malformation that is pushing the mediastinum to the other side. So this is one example of a congenital lobar emphysema. We call it as CLE. So you can see the lung is very dark here, very, very dark here. So this is actually a hyperlucent lung showing, which means hyperlucency means more air, which is suggestive of a emphysema. In this condition, it's a congenital lobar emphysema. Typical location is the left upper lobe. That's what you're seeing here. So all these are some examples of congenital pulmonary malformations, but the most important being the first two images only. So these are going to be the most important. Remember, this is the most important. If they give this kind of an image where the blood supply comes from the aorta, straight away you're going to diagnose a bronchopulmonary sequestration. So that concludes our basic topic. I think it clarifies a lot of things. We have discussed a lot of things. In the next section, we are going to move on to the pulmonary physiology.